If you are just if you are just joining us, one housekeeping role to please start with is we have translations available in French and in Portuguese. If you can please pull up the slide with how to get to your translations. If you are able to find this icon and choose a language that you prefer, this icon might either be present at the bottom of Zoom or under the More icon. We'll pull this information up in a couple of minutes, and we have a team here who can help you troubleshoot if you can't get to your preferred language. Even for the panelists, please make sure to go to the More icon and the interpretation symbol to then choose a language that you prefer, because we do have some panelists who may speak in Portuguese, and then we also have French translations available. So make sure that if you're an English speaker, to be in the English room. And the room that you are in, it should reflect, the language should reflect at the bottom of your Zoom. I see colleagues here from Burkina Faso and from Brazil. So if you prefer Portuguese or French, please choose those rooms for translation. Okay, great. So just repeating to please choose the right room for translation for language. Okay, I think with that we can get started. So welcome everyone. Good morning, good afternoon, good evening. We are really pleased to have you here today. You will see that our team is sharing some resources on. I see the note about my voice. Hopefully this fixes it. So our team is sharing resources for this webinar that might be helpful. We're excited to get started on the Digital Health Exemplars webinar series. Today's focus and the webinar that you're joining, in case you're unsure what you're joining, is on governance models to drive digital transformation. Okay, I'm glad that it is loud. Thanks, Divakar. Governance models to drive digital transformation with insights from several countries. My name is Smisha Agarwal. I'm an associate professor of digital health at Johns Hopkins, where I direct the Center for Global Digital Health Innovations. Let me talk briefly about the Exemplars work before we get started with the core of today's panel. Next slide, please. So the Digital Health Exemplars program is part of Exemplars in Global Health. And the approach that we have taken here is to identify 5 exemplary countries, Rwanda, Ghana, India, Brazil, and Finland. As you can tell, these countries are in different geographies as well as at different levels of digital maturity. But what is common is that they are leveraging digitization to advance primary healthcare in their countries. Next slide, please. So this initiative is part of a multi-partner group collaboration that you see here. Our center, in collaboration with 5 in-country partners, Africa Quantitative Sciences from Rwanda, University of Ghana, IHMR from India, and EAPS from Brazil, in collaboration with the ministry in Finland, are working together on looking at the drivers of digital transformation nationally. And then the second group that you see here is the World Bank and the Joint Learning Network that has kindly convened a group of over 15 country governments that are working on a joint learning network on digital health. Then they're working on a variety of knowledge products that are prioritized by country governments. And so the Exemplar and Global Health team, who I think is represented by Meredith and team here, in collaboration with the Gates Foundation, have kindly brought together these groups to ensure that research is actually aligning with the priorities of the country governments and the learning needs as countries and technical entities are making critical decisions about how to efficiently drive digitization. Next slide, please. So the work is focused on a number of areas of digitization, digital health, maturity, interoperability, thinking about all of the elements of the enabling environment. We're also looking at pathways to scaling digital health interventions. And finally, we are looking at impact and costing of digital health innovations. For today, our focus is on governance models. Next slide, please. And maybe a good starting point for talking about governance is looking at this figure from the 2017 Broadband Commission, which identified 3 types of digital health governance mechanism: a health ministry mechanism, a government-wide digital agency mechanism, and a dedicated digital health agency mechanism. In reality, few countries have such clearly defined governance mechanisms, and we'll have the opportunity to learn from the country government representatives about this today. Next slide, please. So with that, I am happy to introduce our speakers and panelists for today. We will start with a brief presentation by Shivani Pandya and Tiago Hashiguchi, who will be talking about the core findings and framing digital health governance for the group. This will be a brief conversation. Following that, we will be joined by our panelists for today, Marilise Gorens, who is the lead for Digital and AI for Human Capital, Andrew Muhere, who's the Chief Digital Officer in the Ministry of Health in Rwanda, Robson Matos, who is the Deputy Director of Data SUS, Brazil Ministry of Health, and Vesa Romanian, who is the Senior Ministerial Advisor in the Ministry, in the Medical Affairs Finland Ministry of Health and Social Affairs. So with that, I will turn over to Shivani Pandya. I'm also noting that we are sharing in the chat a number of links with detailed speaker and panelist bios, as well as some resources for this panel. So over to you, Shivani.
Thank you, Snisha. I'm Shivani, a researcher with the Center for Global Digital Health Innovation, and I'm excited to share some insights from the Digital Health Exemplars study with you today. Next slide. So we've conducted around 100 interviews with governments and non-government and health system level stakeholders from the 5 exemplar countries of Rwanda, Ghana, India, Brazil, and Finland to better understand the approaches undertaken and the evolution of digital health governance. Today, we'll be breaking down some of those insights into 3 key categories. The first being, what are the pathways countries have taken to construct the digital health governance bodies? The second is, what were the approaches to cultivate an innovation ecosystem? And the third is looking at how was governance considered in decentralized contexts. Next slide. First, looking at how countries have approached digital health governance, we see that across all exemplar countries, a government body has been tasked to handle digital transformation. This is with decision-making power as well as financial resourcing. Looking back at the Broadband Commission report that Smisha shared earlier on the screen with those governance structures, we have categorized the exemplar countries in accordance to those typologies, which is what you're seeing on the slide in front of you. The approaches taken by the exemplar countries vary. Brazil and Finland have a specific body within the Ministry of Health that is explicitly focused on digital health. In India, they leverage a functionally autonomous body known as the National Health Authority, which is responsible for the social health insurance scheme and also to manage digital health transformation. This authority is attached to the Ministry of Health. In Ghana, the operational arm of the Ministry of Health, which is known as Ghana Health Services, is responsible for health service delivery and also for driving digital the digital transformation agenda, alongside the National Health Insurance Authority, which similar to India, also plays a critical role in the governance of digital health. Lastly, in Rwanda, they have leveraged the government-wide agency approach. So that where the Ministry of ICT has placed chief digital officers or CDOs across all ministries, including the Ministry of Health. The CDO leads the Digitalization Directorate General within the Ministry of Health, and you'll be able to hear from Rwanda CDO from the MOH, Mr. Andrew Mihire, during today's panel discussion. Next slide. So a key insight from the Exemplars research is that the health sector does not operate in isolation, and it does benefit from broader digitalization efforts and investments. On this slide, what you are seeing is how countries have approached cross-sectoral and cross-ministerial alignment on digitalization. Why might this be important? One key example is digital identity management, which is largely developed outside of the health sector. We can look to India for an example at the Aadhaar system, which is their unique identification system. The Aadhaar is linked to health insurance programs and can improve access to care for populations. Other key examples include broader investments in connectivity infrastructure, which is not necessarily health specific, but can have cascading impacts on health, such as through the improvement of connectivity at facilities or increased mobile phone access for populations, which can play foundational roles in improving access as well. Next slide. Next, a critical challenge in advancing health sector digitalization is the role of the ICT and IT skills and its coordination and management. ICT units play an integral role in many areas, including the oversight and management and coordination of digital health system and its related data, the provision of software and hardware. They set standards and can ensure adherence to technical and interoperability standards, as well as provide compliance with data protection regulations. In Brazil and Ghana, the ICT departments were housed directly within the agencies responsible for digital health. For these two countries, I wanted to note that these departments have actually existed for decades. In Brazil's case, Data SUS, what you see on the screen, has existed since the 1990s. In Ghana's case, since the 2000s, providing decades of institutional knowledge and capacity. In Rwanda and Finland, there is no explicit health ICT body. The digital health governance body identified takes on some of those roles. In contrast, in India, ICT services are external to the Ministry of Health and service a wide range of ministries. Another example of cross-ministerial and sectoral collaboration around digitalization. Next slide. So looking at data privacy specifically, we also saw that data protection authorities were found outside of the health sector. These are autonomous bodies that are specifically tasked with facilitating compliance with each country's respective data protection laws and regulations. While they maintain independence, they do coordinate with the health-specific ICT bodies we discussed earlier on the earlier slide to ensure regulation and compliance. Having it be a separate body outside of the health-specific ministries provide a clear distinction between health-specific governance and then data protection oversight, potentially serving as an additional layer of accountability, as well as ensuring specialized oversight for the complex technical and legal dimensions of data protection. Next slide. So moving to the second cross-cutting theme, we wanted to see what pathways countries have taken to drive innovation. Governments may not always have the capacity in-house to develop and test solutions, so it underscores the importance of identifying strategies to foster innovation with and for the public sector. In Brazil and Finland, we saw public academic partnerships with universities to drive public service innovation. On the slide, you see in Brazil a partnership with a federal university to develop a nationally scaled electronic health record. And in Finland, you see another partnership with a university hospital system to develop and implement a nationally scaled e-health services platform for both citizens and providers. These cases provide compelling examples of how to leverage the academic sector, either through contracts and financing for public sector innovation. While on today's webinar, we are focused on this public academic partnership model towards innovation. If you are interested in exploring further this topic, particularly with regards to the role of private sector engagement, we are planning to offer additional insights in a forthcoming webinar focused on the role of private sector for digital health transformation. Next slide. Lastly, we focus on a critical challenge: governance models in decentralized health system context. Specifically, how do countries facilitate alignment and compliance at the subnational level? We were able to see these approaches undertaken in India, Brazil, and Finland, countries with decentralized health system contexts. The figure you see on the screen showcases what we saw. At the national level, ministries of health establish the policy framework. They set strategies and standards, such as interoperability standards. And at the subnational level, such as at the state, municipal, or district level, they are required to be aligned with these national level priorities. But how do they foster this alignment? So in some country contexts, there may be provision of software, hardware to facilitate the uptake of digital solutions, and therefore integration with reporting requirements, for example. And then at the subnational level, because there is not an emphasis on a one software fits all approach, it allows subnational level governments to maintain autonomy in procuring the best solution for their needs, as long as it meets the integration requirements at the national level. And third, critically, there may be financing provided from national governments to the subnational level, which could be tied to improving infrastructure, project management, or for specific data reporting requirements, which really incentivizes compliance from the subnational level entities to be aligned with national level priorities. On the screen, you see some examples from India, Brazil, and Finland, and these examples can provide some approaches or considerations for other decentralized health system contexts. Next slide. To close out some of the insights from the exemplar study, the slide demonstrates some of the key drivers of change with illustrative examples from the exemplar countries of Rwanda, Ghana, India, Brazil, and Finland. Some high-level key drivers, some of which we discussed today, included cross-sectoral advancement and alignment with digitalization, national level health IC coordination, data protection regulation outside of the health sector, innovation approaches, and then strategies to facilitate adherence in decentralized contexts, amongst others. Next slide. We are planning to share a report of these findings in the coming weeks, so please stay tuned. That is a forthcoming report we're hoping to share. But I will now pass it on to Tiago from the World Bank to share more about the Joint Learning Network's Digital Health Collaborative. Thank you.
Before we move on to Tiago, just a few quick housekeeping announcements again. If you're just joining, we have translations available in Portuguese and French. You can go to the world symbol in your Zoom to access those translations. The slides and the translated webinar will be available to all the registered participants. And then what we find repeatedly is that any conversation about governance, since it is so much in the details of how governance is structured, quickly becomes an acronym soup. And so what you see in the chat is my colleague Lena Khan sharing a link where we have detailed models with the acronyms and a guide to acronyms, especially as we invite our panelists to speak so that we all have a common set of resources to follow. Okay, Tiago, thank you, and over to you.
Thank you, Smisha. Hello, everyone. So if you could go to the next slide. Thank you. The Joint Learning Network, or JLN, is a country-driven and country-led network of 40 low and middle-income countries whose practitioners come together to learn from each other on challenges and pragmatic solutions related to universal health coverage. The JLN launched a peer-to-peer learning collaborative on digital health in November 2023 with the intention of facilitated learning on the implementation of digital transformations for healthcare systems. Participants of this collaborative span from 15 member countries and 2 observer countries. Technical facilitation for this collaborative is provided in collaboration with the Digital Health Exemplars program. If you could go to the next one, please. As part of the JLN's collaborative learning model, the collaborative members, who are mid to senior level officials from ministries of health, ICT, and the like, come together to identify priority areas, and they did so for learning on digital health when the collaborative launched. These discussions on the priority areas led to 5 knowledge products, which I will show on the next slide. Since then, collaborative members have been a part of the co-development process for each of the knowledge products through combined virtual and in-person engagements. They engaged in deciding on content to include in each of the knowledge products and contributing country experiences related to them. Next slide, please. The 5 knowledge products that were agreed on by the participants are shown here. Those on the left panel are getting finalized, including the how-to toolkit on digital health governance. All products will be available on the website linked to the QR code on the left. The next slide, please. As I mentioned, the collaborative is finalizing a knowledge product on digital health governance. It will include sections on definitions, key terms, and concepts around the topic. What are some of the key dimensions of digital health governance, and how to put it into practice with key activities over time. It will also feature a brief discussion of lessons on digital governance from non-health sectors. Officials from 8 countries have engaged in the co-development process, along with representatives from regional digital health networks. I will now give you a very quick preview of 2 aspects that we discuss in the report that are relevant for the discussions today. Next slide, please. First, how should a country or region select a digital health governance institutional model or mechanism? There are pros and cons for each of the 3 stylized models previously shown. For example, the health ministry mechanism may provide easier alignment between the national health strategy and the digital health strategy, something that may be more challenging in the other 2 mechanisms. However, this model requires significant digital skills and capacity within the Ministry of Health, which may not be available in countries with lower levels of digital health maturity. In that situation, a government-wide digital agency mechanism may be better suited, although the problem may then be a lack of health sector-specific understanding and knowledge. A model that may combine characteristics from the previous 2 and sits somewhere in between them is the dedicated agency mechanism, which has the benefit of being more nimble and less impacted by leadership changes, but that can also be its weakness, as the coordination and collaboration issues may limit its impact. Next slide, please. Through virtual and in-person engagements with member collaboratives, with members of the collaborative, we have put together a list of factors that could help countries choose an institutional mechanism. In the interest of time, I will not go through each one, but the report contains a detailed discussion of each and hypothesizes how each consideration may affect the choice of institutional model. To illustrate, the dedicated digital health agency model could be less suited in a country with limited fiscal space for digital health initiatives, while a government-wide agency model could be better suited if digital maturity is low. In the next slide, please. The report also considers how to put digital health governance into practice, learning from countries which have gone through several phases or iterations. The picture on the left illustrates how a single digital health governance initiative or program is initiated, planned, implemented, monitored, and evaluated. The picture on the right illustrates how initiatives and programs build on each other, often building on incomplete programs or initiatives. The considerations shown in the previous slide may change over time, leading countries to embark on new initiatives and programs. For example, digital health maturity and skills may improve over time, and political support may increase. These changes may lead countries to change their institutional models or start or reorganize digital health governance initiatives and programs. While this is a very short preview, the report is coming out later this year. I very much look forward to the country presentations and discussions. Thank you.
Great, thank you so much, Tiago. With that, we can move on to our panel discussion. So maybe as Lena, you're setting up the panelists, I will ask Marylise to first. There are a lot of findings and observations that we shared from some specific countries, and then Marylise, it would be great to hear your reflections on how these are relevant to other country contexts as well, drawing on examples from other countries.
Sure. Thanks very much, Smisha. Just making sure you can hear me.
Yes, we hear you. Thank you.
Excellent. Thank you very much. You know, first of all, I think that the work has been done both under the Digital Health Collaborative as well as the Exemplar series showcases the importance, but also the massive effort that it takes for governance to work. And what I mean by this is that we have seen over the last 2 decades several efforts have tried to accelerate digital transformation in the health sector. We have seen countries try, for example, to manage and lead these digital transformations through technical working groups and different efforts of the kind. But inevitably, those efforts fail in the sense of them remaining pilots. And so I think what the country and the work that has been done really shows us is just how core good governance and contextually relevant governance is for digital transformation to work within the health sector. I know in the work that we do at the World Bank, the issue of governance and how to make sure that governance works well is absolutely core. Whether it is a temporarily constructed unit like the Digital Transformation Office in Indonesia, or whether it is a digital health agency created through an act of parliament in Kenya, or other structures that have been put together. The time and effort that countries spend on creating these contextually relevant governance structures is absolutely essential. Because once there is a governance structure in place, there is senior leadership accountability, and budgets can be assigned for the digital transformation to work. It is really important for such governance efforts and governance structures to have accountability and a voice at the most senior levels of government, because we know that digital transformation affects every part of the health system. Be it how human resources are allocated, how services are delivered, how the supply chain is managed. Every part of the health system has a digital transformation component. The second thing that I'd like to point out, and I think is that we will see in the work that have seen in the work that's been done, and that we also see in the context in which we work, is that governance structures may change over time. So one might have a governance structure that is sector specific, that transitions to a government structure that is all of government wide. One may have, as one saw in Rwanda from the very early days, a very deliberate effort to bring the governance structures, the government-wide governance structures, as well as the sector-specific governance structures together. And that change is healthy because it signals that there's a certain level of maturity in digital transformation that has been achieved. I think many countries that we've seen many countries really struggle with what governance structure is the best one. And I think our answer is always, try one out, see what works for your context. And if it doesn't work, there should always be the flexibility to change those structures to make sure that it suits the needs on the ground, the political will that may exist, as well as the right opportunities. In India, for example, the National Health Authority, which really manages the social health insurance scheme, was the entry point. So the claims management system was the part that was built first, and governance around that, with the other governance pieces added at a later stage. So one also needs to find, and that's my third point, the right openings and making sure that the political will exists. Because too often we've seen digital transformation being relegated to the ICT department of a Ministry of Health, not having the senior leadership focus, not being tied into wider health system transformation, and therefore not achieving its full potential. Thanks, Michelle. I hope that's useful for the
Yes,
conversation. Back to you.
thank you, Marylise. I think with that, if we can also have the panelists on their other panelists on their videos, Rapsin, Andrew, Vesa, that would be great. Thank you so much. Hi, thank you so much. I think your point, Marylise, on how governance systems need to evolve is a great point to transition to Vesa. Specifically, Vesa, Finland had a health reform in 2023 where 309 municipal representatives that managed services were centralized into 21 well-being service counties. And you created a new unit for digitalization and for information management. Could you speak to what motivated this change and how it will impact digital health decision making in Finland?
I just opened the mic. Okay. Yes, thank you for invitation for this panel also with the interesting issues around. The actual goal of the reform, which is the largest societal reform in Finland after the World War II, on top level, its goal was to safeguard equal and quality healthcare and social welfare services for all, of course, and to reduce inequalities in health and well-being. And it's also stated that healthcare and social welfare services will use the best and most efficient or efficacious practices. So the aim was to ensure the availability of skilled labor, which we are still lacking, improve safety and respond to the challenges arising from various types of changes in society. Okay, that stated, we can also say that when it comes to health care information systems and so, we wanted to consolidate services under less responsible organizations or under a less amount of bosses and leaderships in order to keep the steering more functional when if you compare to the 309 municipalities. We also lifted social welfare and healthcare issues and emergency services to a regional level, and we created a new organism, so to say, the well-being services counties, as you told. And so there was a division of labor, division of finances, and so forth, and the just created well-being services counties. They get most of their finance or the money from the state budget nowadays. That's based on a formula and so forth, kind of need system. When it comes to ICT issues on national or regional level, the reform was for the public health care mainly. So it's easier to maintenance and develop of the services when there are less decision makers. That's kind of message what we have learned, and I pass it on to the other guys here.
Great. Thank you, Vesa, for that insight. Maybe moving on to Repson, data SUS, and so for the attendees, data SUS is equivalent, as Shivani shared, to an ICT-focused entity. And so in Brazil, data SUS has been around since early 90s, and CGDHI, which is the focused digital health entity, is relatively recent. It was established in 2023. And one of the decisions that has been made is to move data SUS as part of CGDHI. Could you speak to why that change has happened, and also speak broadly to, in the same theme of transformation over time, how data SUS has adapted over the years to focus on the health sector? Over to you, Rapson. And just maybe one other, Rapson, if you're speaking in Portuguese, that everyone should pick, English listeners should pick the English translation. Okay, over to you, Rapson.
Perfeitos, Misha.
Perfectly, Misha. First of all, I want to thank you for the invitation. It's an honor to be part of this panel. And then regarding our Department of Information of the SUS, is a historical department inside the Ministry of Health. And for a long time, it acted to support, how can I say, administrative support. The Ministry of Health along the 1990s, it was really focused in developing systems of health in many areas, whether a pharmaceutical area, assistance, or in primary health. But the problem was that along the years and the political and administrative management, it was getting bigger. So we were in a situation that we had different kinds of system of information. Many times we had redundant systems because they were dealing the same information in a different ways, and that caused a big fragmentation of data. And that started to change. And actually we had a significant change starting in 2020 with the creation of the National Network of Data in Health. Then the focus of this department started to change. It no longer is focused in the creation or development of systems of information health, but it starts to focus in the data, in receiving and transmitting data in health. So this national network of data is based on that. It uses a standard of interoperability, which is HI codified, in which we start to think more about the data in information health to generate knowledge and to help the decision makers. In 2023, we create the Secretary or the Division of Information in digital information. This is the brand new division in the ministry. And data SUS is incorporated in this structure. This made that the focus of the department start to be more integrated to the information and no longer in just administrative criteria or development of systems or just analyzing contracts. That made a huge difference, a great evolution, because now data SUS, they have their own product. It's no longer just a support area of the Ministry of Health or the complementary health, but they have their own product, which is the National Data Network of Data and Health. Is some platform that can disseminate the data of this national network. We have one platform for citizens, another one for the health professionals, and we are developing a platform for the managers. And now it's important to mention that before the creation of this division, Data SUS was the Department of Informatics of the SUS. When it was created in this division, it started to be not only the part of IT, but also and part of information. Although it was just a simple change in the name, it gave a change in the posture and the focus, especially when talking about governance and health, to deal with this information, because it's the great patrimony we have. Although it's a decentralized system, we are on one only system of health. So we are in many states and cities, and this makes us having a rich legacy of information and health. And we need to standardize and disseminate this information with states and cities through this network of information.
Great. Thank you, Rapsin. And I think that's really helpful because the transition in Brazil was really focused on, as you pointed out, focus on IT and being like a technology hub from an informatics center that is catering to the broader needs of the health system. I think of that as most of our institutions have a division that can help us like fix our computer viruses and sort of the smaller problems. But how do we go from that to thinking about systems? And so I think a point that I took away is that over time, data SUS has evolved to take that role of thinking about broader informatics lens. Let's move on to Andrew. Andrew, in Rwanda, it's a very different governance model, where whereas in a lot of other countries there is one unified entity for digital health governance. In Rwanda, there is a network of chief digital officers, and for those who are wondering about the governance layout, there is a link in the chat that lays out the governance structures of each of the countries. So could you speak, Andrew, to what has worked well with this model? And you also being a chief digital officer, speak to actually what has worked well for you. And we would also love to hear you talk about some of the pain points that emerge from this model.
Yeah, thank you. Actually, for Rwanda, is not far away from what my colleagues, my panelists really highlighted. But for us, actually, it's rooted much more on the challenges. And thank you for inviting us. I've been working with the Ministry of Health till 2011. I think I'm going to give my experience with having a delicate governance. So I think this governance topic is very interesting, looking at the experience that we've been facing for long. So maybe coming back to Rwanda, what we've been facing actually initially before we had this new structure that really strengthened our governance, we used to have 3 departments: IT department in the Ministry of Health. One was Health Management Information System. Then another one was in charge of ICT. The HMIS, which is Health Management Information System, was in charge of data. But they had also their digital innovations that they are working under planning department. Then that time we had ICT department was in, under corporate services. They had also their line and their priorities. Then we also had e-health. But the 3 were in different departments, having different head of units, achieving different strategies. So you can imagine how we've been misleading partners, because if partners comes, by that time I was the head of HMIS, the data management. My priority was much more on collecting data and making sure that the data is available. So when I meet a partner, I have to drive them towards that direction. Then e-health the same, ICT the same. ICT was much more on the infrastructure, but most of the infrastructure was just making sure that in Ministry of Health, internet is there, then internet is at the health facility, but it was not, there was no linkage between infrastructure and digitalization. So one is having partners confused because they are meeting different departments with different priorities. Secondly, there was priorities from programs that were driving us. You find each program, they have their own system, like what they have in Brazil. Like you have vertical platforms that are solving problems in malaria, HIV, they have their platforms, NCD, they have their platforms, immunization that they have their bottom. Then we ended up really confusing clinicians. Then clinicians were seeing digitalization as a burden rather than a solution to solve and improving the inefficiencies. So in between there was a restructuring to make sure that we really align our digital transformation based on the national strategy. This really restructuring was to make sure that the Ministry of ICT is the one leading the digital transformation. And that's why you can see that we have Chief Digital Office that is sitting in the Ministry of Health, but it's a team from Ministry of ICT sitting in the Ministry of Health under another entity called RISA, which is Rwanda Information Security Agency, which is implementing entity. Ministry of ICT is in charge of policies, strategies. Then RISA is in charge of implementation. So for us, we are working under RISA, but sitting in the Ministry of Health. What does it mean? The benefit of this is that we are sitting in the Ministry of Health implementing national strategy, Ministry of ICT strategy, which is much more on improving patient care. So currently, actually looking at before and after, before it was us looking at the data that are needed for the programs and others, but currently we are looking at the patient journey. How could we improve the patient journey to make sure that the patient experience is better, but also clinicians improve their efficiencies in the process, but also we improve working with stakeholders, the different partners and stakeholders. So as I'm saying currently, looking at this new structure, at least we are able to have a clear vision that we are implementing together with different stakeholders and partners. Secondly, funding. As I said, funding was moving in different departments. Currently, we are really aligned on the funding and priorities that we are going to implement the funding. As I'm talking currently, we have implemented electronic medical records in 7 districts. We are scaling it up all over the country, with aiming at improving the patient care. That what I said is like making sure that the clinicians are able to look at the patient and also the medical history of the patient at any time, anywhere. So here we're talking about one patient. Initially, it was many patients who goes in different services, but now is one patient accessing different services, which is an improvement that are coming from this governance part. So I think I will not say much because what we are looking at much more in this new governance is making sure that what we are implementing is sustainable. We are able to really converge all funding into these priorities. We are aligned to the government strategy and the clear vision of Ministry of ICT towards Ministry of Health. So thank you. That's what I could say. Yeah.
Thank you, Andrew. And I think one of the points that you made is also about how the governance has, and restructuring or thinking about the governance has helped in defragmentation of the patient experience, right? And so, because I think it's sometimes harder to relate how governance can impact a patient journey. I see, just to pick up on some of the questions in the Q&A, and I'll come with this question about financing to all of our panelists. One of the points that Mary-Lise made is that a committee alone is insufficient, right? That there has to be a clear mandate for how the budget will be allocated and financing will be structured. So Andrew, could you speak to how financing is allocated with this model of especially with the new DDG, the Digitalization Directorate General, and maybe I'll ask a similar question to you, Vesa, about how does the Ministry of Social Affairs work together with the Ministry of Finance to get the budget for digital health services. And maybe after Vesa, Robson, a similar question to you. I see Robson. Okay, there you are. Similar question to you about how the change of data source, where it sits, how that has changed maybe the budget allocation available for technology. So a financing team next, starting with Andrew, please.
Yeah, actually, thank you. For us, what we have done is that as soon as we had this new governance on the Ministry of Health related to digital, so we tried to bring to map all stakeholders and partners. Now we have what we call technical working group, where we present status and gaps that we have in digital transformation. So we have costed everything. So everything is costed, and the good enough is that previously we have changed, we have really updated our health sector strategy. So among 7 priorities, digital transformation is among 7 priorities. So this one makes it to be among 7 priorities that have to be financed. And again, what I've seen when partners really see that there is a very clear plan and vision for anything, or most of the time they really join. So currently, that's how we are really financing the digitalization and digital transformation, is making sure that we know where we are, the gaps, and also we make sure that we have a forum where we discuss with different stakeholders to align with their expectations.
Great, thank you, Andrew. Vesa?
Yes, thank you. I have to say that the relationship between the Ministry of Social Affairs and Health and the Ministry of Finance it's not love and hate type of situation, but we usually discuss these kind of matters as investments for the future, and we propose in the state budget proposal for the Ministry of Social Affairs and Health issues that must be done in our minds, and we propose that the Ministry of Finance that will look whether it goes or not. Eventually, it's going to be the Board of Ministers, the government board, that will look at the issue and accept or not accept. We do that 2 times a year, in the spring and in the autumn also. We have an estimate that now in this situation where we have the state budget funding for the public health side, it's something like 4% of the state budget that goes to this healthcare and social welfare and emergency issues. In Finland, I have to stress that we made a strategic decision already in 2006 or 7, so that we put the customer or the patient on the driver's seat. So we let a little bit professionals aside, and we have created our nationwide shared services according to that strategic decision. I do have some detailed numbers also regarding what kind of issues there are. In the older world, the costs were borne by municipalities or joint authorities at the local level, such as, for example, hospital districts. But now
these are the costs for
ICT issues, for example, yes, and also for running the functions as a organization. But usually we have got the financing from the government side, and one of the issues is that we have a long standing statement from the governmental side that hasn't changed during when we brought up the nationwide services, so that it didn't depend on the coalition of parties that were in the government board, but they financed and they saw that okay, these guys developed this issue, so we get money for the development also, and running the services, of course. But it's not love and hate, but it's about discussion and fruitful
Thank you,
agreement between the ministries. Yes.
Yeah, and I'll pick up on that thread of a fruitful discussion between the ministries shortly. But over to you, Rapsin, about budget allocation with the new governance model.
A partir da criação da Secretaria de
once
Informação e Saúde Digital, uma das suas
ICT
primeiras medidas
department
foi a
was created,
criação
one
de
of the first
programa
measures was to
específico
create a specific
nacional para a
program, a
evolução da saúde
national-wide
digital
program for
em
digital
estados e
health
municípios.
evolution in different states
E
and
nesse
municipalities.
programa, pela
And within
primeira
this
vez no
program, for the
Brasil,
first time in
se
Brazil,
deu repasse de
there was
financiamento específico para a
a
evolução da saúde
specific
digital.
funding for
Dessa
digital
maneira,
health
então,
development. So this is how
foi aplicado aos estados e municípios do
we were able
Brasil
to apply to the
questionário,
states and
né,
municipalities.
primeiro
We
para uma
applied
avaliação
first a
do nível
questionnaire to assess
de maturidade
the
em
level of
relação ao uso de
maturity in
tecnologias,
terms
de
of technology
informática,
use,
uso de
informatics,
padrões de
use of
interoperabilidade, uso de
different
sistemas
interoperability
de
standards,
informação,
systems,
né? E também foi aplicado
and
questionário específico para
there was also a
levantamento
specific
de
questionnaire
índice
to
nacional de
understand
maturidade
a
digital,
national
né?
maturity
Tendo esses
index for
documentos em mãos,
digitization.
essas
And having
informações dos
these
estados e
documents, once we had
municípios,
the information
então,
from states and
posteriormente,
municipalities,
os estados e municípios eles
later on,
apontam
the
para o
states
Ministério
and
da Saúde
cities would
plano
then
de ação,
point,
né,
would present a plan of
para os
action to
próximos
the
anos
Ministry of Health
e em
for the
relação a
next few
isso
years.
é realizado repasse
And based on that,
financeiro
so there is
específico para essas
specific
ações,
funding
de
for
maneira
those
que
specific
elas estejam
actions
focadas
once
em
that they are
evolução do
granted that they are
ambiente, do
focused on
ecossistema
the
de
evolution of
saúde
the
digital
ecosystem
do
for
estado e
digital
do
health
município, a
in the
adesão
state or the
aos padrões
city,
de interoperabilidade,
compliance to the
sobretudo
interoperability
a adesão
standards,
à
and
Rede
above
Nacional de
all,
Dados em Saúde
compliance
e os
to
modelos
the
informacionais
national
que estão
information and
desenvolvidos para
digital health
a nossa
information
rede de dados
models
e
for
também no uso
our
das
own
nossas
database
plataformas,
and
né,
the use of
plataformas
our
de
own
inovação, plataformas de
platforms
disseminação
for
de dados.
innovation or
Então,
data
nessa
communication.
nova estrutura de
So in this
governança e por
new
meio desse
governance
programa se
structure
criou
and using this
arcabouço
program,
de
we created
financiamento
this
específico
specific funding
para as
framework
ações de saúde digital.
for
E por outro
digital
lado,
health
também nós
actions.
temos
And on the other
evoluído
hand,
pouco
we've
o
also
nosso
been
arcabouço
developing
normativo
our
do Ministério da Saúde para
standards
incentivar o
framework
envio
to
de dados e
encourage
informações por
submission of
parte de
data and
estados e municípios
information
para a Rede
from the
Nacional
states and
de Dados em
municipality
Saúde, né?
into the
Isto é, a
national
adesão à
network.
nossa rede
So
de
this is the
informação
compliance to
de
our
maneira que ela
information
realmente seja uma
network
rede
so
que
that it is
contenha
truly a
todo o
network with
arcabouço
all
informacional de saúde
of
do
the
cidadão,
information,
né? E consiga, assim, realmente
medical
se
information for
configurar como um
citizens so
prontuário
that this is
único,
truly
prontuário
used
unificado,
as a
e assim
unified
promovendo a
medical
continuidade de
record,
cuidado do cidadão.
therefore promoting more care for the citizens.
Thank you so much, Robson. I think one of the pieces of research that the EAPS team, as part of Exemplars, has led demonstrates how the financing model that you just outlined, where digital infrastructure is incentivized through the primary healthcare scheme, has actually facilitated very equitable adoption of digitization, even in the more rural areas, because we typically think that digitization will take time in rural and remote areas. In the case of Brazil, we see quite the opposite, where even the more remote and rural municipalities actually have high level of digitization. Exactly, I think, in large part because of the financing model that Rapsin identified. And I think that's also a result of the close coordination between primary healthcare and digital health bodies within the country. We have lots of questions coming in, and I'm trying to get through a few more of these. First of all, Mark Landry has kindly shared a good resource and an example from Thailand that was led by Dr. Boon Chai and others, which might be a good resource for folks. And Dr. Anthony Ofuso from Ghana, we're glad to have you on the call. But I think you raised a really good question, and I would love to hear the panelists, including Marilise. I know you have a lot of thoughts on this about how a governance structure like Rwanda, where there is sort of an embedded nature of how digital health is conducted. I think also in other countries, how do we define the lines of reporting and accountability? And also, how do we navigate some of the conflicts that might arise between the Ministry of ICT and let's say the Ministry of Health? Or I think in some countries where there is a separate entity for digitization, how do we define those lines of responsibility? Maralise, if you're still online, maybe we can start with you and then move to other panelists.
It's an excellent question, Smisha, and it really gets to the issue of where the ultimate accountability lies, right? I firmly believe that if one gives a unit a budget allocation and specific results that they have to achieve, that forms the nucleus of what such an accountability measure and reporting structure should look like. Now, for a digital health unit, it is extraordinarily important that they work really closely with all the other units, right? So I think one also needs to distinguish between the reporting and accountability that sits with having a budget and a work plan and specific national results, vis-a-vis the very close partnerships that need to be built with subnational structures, with entities that already run health information systems, because very rarely is this a greenfields environment where we're starting from scratch, with the private sector, with the public sector, with healthcare workers and health system structures, everyone from community health workers to the central medical stores and so on. Because digital is so infused and infiltrated really every part of the health system, those, even though they're not reporting line, those communication lines are incredibly important to make that work. And I would almost argue, someone asked the question earlier, what is the best governance structure, right? And I think that's a question we can't answer, because I don't think there's one governance structure, right? I think it is about being crystal clear about what the central unit is responsible for, and the central unit really seeing themselves as a join the dot, right? Someone who brings all these things together and therefore needs very close communication lines within the health system, but also outside the health system, right? With the Ministry of ICT, with the Ministry of Home Affairs, with, in Nigeria's case, with the National Identity Management Commission for the use of digital IDs, right? Or Aadhaar or ABBA numbers, as was done in India. So this really needs to be a unit that is plugged into such a wide range of things that I would argue that communication and communication lines is really of such a governance unit or team, whatever that looks like. Over.
Thank you, Maralise. I think one of the points that Maralise raised, and I also see a question about it, which really complicates the role of a clear articulation of roles and responsibilities, is also that, especially as we think about DPIs, digital public infrastructure, that a lot of the infrastructure on which health programs are built, for digital health programs are built, need to be supported by other ministries. So maybe I will turn over, Vesa, to you for your insights on coordination and division of responsibilities.
Good. In the schematic picture, is given for Finland the Ministry of Health and the Ministry of Finance. And I would interpret this situation so that for the other ministries than the Ministry of Finance, it was a kind of Wild West situation before 2015 around. So I would call Ministry of Social Affairs and Health a ministry with substance issues, and that still are under the other ministries when it comes to the substance issues. So issues of e-health or digital health or healthcare, social welfare, they are issues to be decided within the Ministry of Social Affairs and Health. Whereas the Ministry of Finance, they run a unit for public information management. actually, and that has been built something like 2015 and confirmed in 2020 when they have responsibility for non-substance type of specific issues, meaning data safety and these kind of issues. So they come together and we do it jointly with ministries and Ministry of Finance, and they have a clear role when it comes to other than the substantial issues that are taken care of the other ministries. So maybe this is not an explanation, but we have divided responsibilities so that there's the general approach by the Ministry of Finance, and then there are the substance-specific issues that are taken care of the other ministries. And this has worked rather well. As I stated before, it's not a love and hate type of issue, but it's a kind of joint effort towards the same goal.
Vesa, since Finland in our exemplar countries is most far advanced on the digitization spectrum, can I ask if the roles and responsibilities have shifted over time as things have matured and advanced?
Yes, you may say that, of course. You are the moderator. Yes, and this kind of duality that I explained is a kind of ecological in that sense that there are different ways how the roles and responsibilities between these two ministries, which I know the best, have evolved, and you have to take into account also what kind of reforms we have had, right, or the legislation in place when the issues have been raised. But proudly I can say that the division to this general approach and the division to this very specific substance type of roles have got strength, and it also means that when we have this EU-wide, European states-wide, the healthcare specific space coming, and it's already started March 28 this year, and we have to adjust to European wide of issues, and then things go complicated because it's not the Finnish approach, but it's EU-wide type of approaches, and that's kind of the latest phase, starting with cross-border type of information sharing from 2014 onwards.
Great.
But I think we are still discussing to each other, and we are developing a more deep and maybe more strength-based approach between these two ministries. Thank you.
Thank you. Rapsin, could I turn this question about coordination, roles, and responsibilities to you, please?
Com certeza.
Sure.
Bem, eu gostaria de iniciar minha fala
I'd
falando
like to
que
start
parcerias
saying
são
that
fundamentais, né?
partnerships are essential.
Aqui no Brasil, no Ministério da
In
Saúde,
Brazil, in the Ministry of
apesar de
Health,
nós
although
a saúde está somente
although
aqui, a
health is
gente
just
ter
here, we don't
uma
have
divisão entre
a
outros
division
ministérios, nós
between other
temos
ministries.
algumas agências,
We
né,
have
algumas
some
instituições que
agencies
também são
and
parceiras e
entities
elas
that
são
are also
vinculadas ao Ministério
partners,
da
and they
Saúde,
are
né? Por
connected
exemplo, a
to the
Agência
Ministry of
Nacional
Health. For
de
example, the
Vigilância
National
Sanitária
agency of health surveillance is connected to the ministry, as well as complementary health that also act in the private sector. And those entities, they are part of a committee that manages the e-health, and it's also part of the Ministry of Health, and it's also part of the representative of the state in municipalities. Although we are just one system, but we also have these instances of federal governance and state governance and municipal governance. Although we have this centralized management in health, we have many partnerships with other ministries, especially to exchange technological experiences. In the last couple of years, not only we had the creation of the national network of data in health, but we also created some mechanisms of digital innovation in the Ministry of Planning and Management. So today we have a national portal that's called gov.br, and they centralize many services for citizens. There we have data and information that comes from many ministries, some from the racial equality and the Ministry of Education and Ministry of Health, of course, and the social development. And the RNDS, it's a great partnership that we have with Ministry of Management and Innovation. We have a specific login from the government. We call one unique login. That's an important certification to access the platform of data exchange of the program of SUS, digital SUS, and we are contributing so that this can be integrated to have this information system integrated in RNS. Although we look like just one big block centralized of health, but we have also partnership with other institutions, other ministries, and we are always working in a really close way to the states and municipalities. So now we see that more and more, the more innovation, the more they centralizes the innovation, it loses its purpose because it starts to be bureaucratic, it's slow. So we are always establishing communication with the private sector, with the municipalities and the federal and the state and other institutions in the governance of the federal government.
Great. Thank you so much, Rapson. I think there are some themes that are emerging in some of these conversations, private sector engagement being one of them. For our attendees, that is one of the areas that we will focus on in our learning webinar series. And I think the other theme that is emerging is issues of interoperability. And we will also have another learning session on that. Andrew, before I turn over to you, I wanted to also ask our panelists. This is an opportunity to speak to each other. And if you have questions or clarifications for other panelists, I would welcome those after Andrew comes in. So please be thinking about that. Andrew, over to you. The question really was focused on it was to you about coordination across and clarity of roles and responsibilities.
Yeah, okay, thank you. For Rwanda, of course, we have roles and responsibility of each ministry because currently we are belonging in two ministries, that is the Ministry of ICT and Ministry of IS. But what I've seen that is very important in making sure that there is no conflict is having a clear communication line. That is the other governance structures, like currently in the Ministry of ICT, we have what we have a session where we meet with all chief digital officers from different sectors. Then we discuss and give updates. From my side, I've seen that it's beneficial from most of the sectors, because I can give you an example, like in the Ministry of Health, when we are implementing digital platforms, we depend on the population registry. So at least it makes it easier when you are meeting in one platform where you are seeing it as one, you are seeing yourself as one team. It's like having a football team. All of you are playing in a different parts of the pitch, but at the end of the day, the goal is only when you score in the small one.
Et ici, dans ce système, et c'est important, en fait, on est un peu comme, c'est comme un peu comme une équipe de football. Il s'agit vraiment de cet échange et de pouvoir réellement promouvoir cette interopérabilité, notamment ici pouvoir vraiment se faire confiance. Deuxièmement, au niveau du ministère de la Santé,
whatever we are doing, we are under Ministry of Health. So Ministry of Health is not the one that comes and tells us do this and this. It's a Ministry of Health that tells us what to do, priority, and we work together. So we are also part of the senior management meeting of the Ministry of Health where we discuss all these things. So to make sure that we update them, we also make sure we push the digital health transformation agenda into everything to make sure that we get the funding and also other attention that we need. The last one is the technical working group, digital health technical working group that brings all stakeholders together. Stakeholders means everyone that is not in that forum that I mentioned, they attend the technical working group, then we discuss. So when you have a very good communication line and you make sure that all stakeholders are updated and are also contributing in what you are implementing or doing, most of the time it avoids these conflicts. Yeah.
Great. Thank you, Andrew. We do have our team answering questions on the Q&A. Rapson, there is a question in Portuguese in the chat, if you could take a look at that. But can I open up to the panelists? If you would like to unmute, if there are questions, clarifications for other panelists, I welcome those. Andrew, please come in. Thank you for your hand.
Yeah, actually, I was interested on the implementation in Brazil. I wanted to hear from panelists from Brazil how they are handling the remote area implementation of digital health. So from the Finland, actually, I was interested to hear much more on how government is really supporting all digitalization. So that one also will be interested. So thank you.
And of course, Andrew, those are very big questions. I should say that that as part of Exemplars, we would have documentation, fairly detailed documentation of this, and we will make sure to share that with you. But I see Vesa, over to you before each of the panelists can respond to each other. Vesa?
Okay, thank you. My question to my dear colleagues is that do you let patients or customers to see the medical records of themselves? Because that has been a major driver here in Finland, at least, so that the people have access to their own medical records. Thank you.
Thank you, Vesa. And Rapson, do you have questions for other panelists? No pressure. And Marilee?
Eu já gostaria de responder as perguntas
I would
dos
actually like to answer my colleagues' and questions.
Tudo bem?
That's okay.
Não, primeiro
Yes,
a
please go
pergunta
ahead.
do Andrew.
Well, going back
Nós
to Andrew's
temos
question,
vários, além do programa SUS
in
Digital,
addition
que
to
tem
the
esse foco
SUS
de repasse de
digital
recursos
program
específicos para
with specific
a
funding
evolução da
for
saúde digital, nós
the
temos
evolution of
projetos
digital health, we
específicos
also
também
have
para a evolução da
specific
telesaúde,
projects to develop
sobretudo em áreas
telehealth,
remotas, né?
especially in
O
remote
Brasil é
areas.
país de
Brazil is
dimensões
a
continentais, nós temos
continental-sized
muitos
country,
territórios
and we have
indígenas, né? Muitos
a lot
territórios
of indigenous
isolados na selva
territories that are
amazônica,
very
na
isolated in
floresta
the
amazônica,
Amazon.
e algumas
And
comunidades que elas
we also
são
have some
realmente, o
communities
acesso é
that are
muito difícil, né?
truly
O
remote.
acesso
It's
só
very
por via
difficult to
fluvial, né?
access. You
Às
can
vezes
only
são
access
dias de
these
viagem
communities
para chegar.
by river. It
Entretanto,
takes days to reach them
entre
sometimes. So,
os grupos da comunidade há
and
treinamento para
among
que
the
eles mesmos
groups
se
of the
tornem
community,
chamados agentes
they are
comunitários de
trained to
saúde, tá?
become
Eles
community
sirvam
health
como
agents,
contato direto
and
com
they
o
are
município mais
a
próximo.
direct point of
E
contact
nessas
with those
comunidades nós temos
municipalities, and
investido
we've been
bastante em
investing
telesaúde,
heavily
né?
in telehealth for these communities. Since physicians cannot reach that region, we want to take technology so that the physicians can communicate with citizens in these isolated and remote areas, at least for an initial consultation, at least for a primary health visit. And if it's a more serious case, of course, this patient should be taken to another city, another capital for appropriate treatment. In terms of, so going back to Vissa's questions, we allow the use through an app with their health data. Everything that is sent to the national network, they have access to. So they can see their medical records, their vaccines, their clinical visits, prescriptions, tests that have been done, and some other models that we are now working on and implementing in the national healthcare data system. But citizens can restrict access to other users like medical professionals, but they themselves can have access to all of his information that is available in their registry according to their tax ID information.
I'm glad to hear that.
Lisa, you can continue to respond to Andrew's question as well.
Now you have to repeat.
Andrew, could you repeat your question?
Yeah, actually, I just wanted to hear how the government is funding the whole digital health transformation in Finland. Yeah.
That's mainly done by the state budget. We have different types of development funds also available, and it's based on application. So you have to apply for kind of funding for this and that. It used to be so that we financed the healthcare specific IT around 750 million euros per year, and the level is not less because of the consolidation of systems nowadays. Of course, there are also startups and smaller entrepreneurs who develop their products and try to get them to the system. And for that, we also have some channels which one to use. But basically, you are asking for the government level type of system. It's through the state budget.
Andrew?
Yeah, maybe one question, another question. Actually, I have a curiosity. So thank you for inviting us again. So actually, I wanted to hear how many electronic medical record do you have? Do you have one centralized one? Maybe this is both for the panelists. Is it one centralized? Is it just each site have its own electronic medical record? Because this one is bringing me on the other side of patient accessing his or her records. Yeah.
Should I start?
Please, Vesa.
Our approach has been so that it's up to the organizations to decide. But what we request and what's mandatory, that they utilize the standards that are set by the central government and based on law. So there will be competition between different data system manufacturers and vendors, especially when it comes to the interface of the system, so ease of use. But we have let almost everybody to come to the marketplace, but they have to certify their systems, and that will be checked by a specific authorities. So there's a marketplace, and for example, for hospital care, we have something like 5 to 7 products on the market, and similarly for the oral health care, social welfare, and so forth. So not a monolith, not just one monopolist on the market, but our monopolist approach is for the Kanta services, nationwide Kanta services, where we have these healthy information systems and national-wide repositories and health information exchange. So products has to be adapted based on the standards what we have set for the system to plug in to the national one.
Thank you. Thank you, Vesa. And of course, there are many similarities between Rwanda and Finland in terms of the size. But one of the big differences is, of course, that Finland is highly decentralized compared to Rwanda. More about the marketplace coming up in our next webinar. So I think we would love to hear more about that. Vesa, Maralise, I see you have, please come in. I'll turn over to you. And also, Maralise, we're about 4 minutes short of wrapping up. It seems like the conversation has just got started, though. So, but please come in, and I also welcome your overall remarks, some sort of key takeaways from the webinar, and some action steps for us to think about.
Sure, thanks, Smisha. I first want to respond around this issue about where the health data are kept. I think it's critical. We see countries like India with a very federated and decentralized model where every information system holds onto its own data, and patients give consent for data to be kept for a period of time and shared with specific healthcare providers, to more centralized systems like the Satu Sahat system in Indonesia, where all the data is put into one shared health record. Across, and there are 999 health information systems in Indonesia that all send data, or most of them at the moment send their data to Satu Sehat. There are also countries like Nigeria, for example, that are considering hybrid models, right? Because, and I think every country needs to figure out what works for them. That said, and that obviously where data are kept and how the data are being safeguarded is a critical part of governance, right? And I think when we think about governance, it's about who is the unit that is doing the governing, but it's also about what are the rules of the road. Many countries have data protection laws now, but sometimes they are sufficient, but sometimes we need something more for figuring out how health data will be protected. And I think one action step is for all ministries to look at and make sure that if the country has data protection laws, that those laws are sufficient also for governing how health data are protected. And of course, cybersecurity is a critical part of that. But I want to end in maybe two takeaways from the session. The first to me is that digital transformation in the health sector cannot happen on its own. It cannot happen by health sector colleagues only talking to other health sector colleagues. It is absolutely essential to think outside the sector as well, because there are resources and shared ways of financing some of the digital transformation investments in the health sector that can't happen in a shared way if we're not thinking and talking outside the health sector. We also need senior level commitment, and a Minister of Health or a Director General or a Principal Secretary who absolutely sees digital transformation as a key gateway, a key vehicle for health system transformation is absolutely essential, and governance and everything else will flow from that political will. And lastly, to say financing, we can have all the governance and all the rules and agreements in place, but if there's no money available, these systems can't work and governance can't properly be done. There's a lot of talk about financing at the central level. The nut we haven't yet cracked that I think is a collective action point for us to move forward on is how digital transformation aspects of health systems and health services gets financed through countries' health insurance schemes, be it public or private health insurance schemes. There are not many countries that are doing that. If a pregnant woman receives an AI-enabled ultrasound, how does that get reimbursed vis-a-vis a pregnant woman who doesn't receive an ultrasound or receives an ultrasound that is not AI-enabled? just to give an example of some of the financing areas that we need to think about as well, and not think about digital transformation almost as only a tax or an expense that always needs to be finalized from the central level. I hope those are some useful thoughts. Back to you, Smith.
Thank you, Marylise. I think that's a great summary, and also you're right on dot on the time. I want to take this time to thank our panelists, Marylise, Vesa, Andrew, and Rapsin, to take time out of your very busy schedules. Also, this might be the first digital meeting I'm at without major technical challenges, technology challenges. So I'm pleased about that. This is just the first of what I think will be a longer series of learning opportunities for us to connect and talk about how digitization is happening to advance primary healthcare. I see that there is a barcode that's come up for how you can register to hear more about this. We share some of the research insights and snippets from these discussions from the Exemplars work on our roundup. Please feel free to sign up. Thank you everyone for your time. Really pleased to have everyone on, and please a virtual applause for our excellent panelists today. Thank you.
Thank you for the moderator. Excellent work.